So good morning or good afternoon, I guess, for most of you. Although I see some people on the left coast of the United States, so it's obviously morning here. Maybe we'll give it another moment or so where the participants are rolling in. It's 7:02. We want to make sure we have enough time for excellent presentation from Dr. Norgaard, and then the case discussion from Dr. Pontone, which I think will also be not only informative, but highly engaging, as Gianluca always is. For those of you who are on the line who don't know Bjarne is not only a good friend and a tremendous collaborator of mine, he's been a thought leader in CT integration and structural heart disease, having just published one of the seminal works a few months ago in JACC looking at post-implant leaflet thickening and clinical outcomes, published extensively previously in CT for TAVI, but the reason he's speaking today, of course, is because he is a pioneer of not only the validation and a trialist in FFRCT, having been the principal investigator of the NXT trial published in January 2014 in JACC. It's hard to believe it's 3 years ago. But also as one of the first, really the first clinical adopter, and not just clinical adopter from an early experience perspective, but wholesale programmatic integration of FFRCT as a supplementary and additive tool for patients with stable chest pain, and very much now looked at the clinical outcomes of such patients and has published extensively as we've seen recently in JACC Imaging and journals of the like. So we thought it would be a good opportunity for Dr. Norgaard to educate us all based on his experience about the importance of image quality, appropriate CT scan protocols, and in particular, the use of beta blockade and nitroglycerin to optimize diagnostic performance and clinical utility of FFRCT. So thank you again, Bjarne, for obliging us this ask, and look forward to your talk. We're going to have Dr. Norgaard speak, and then we'll open it to the floor for questions, and then we'll follow with clinical cases from Dr. Punt. So we'll give it another moment. We may have to rejig the schedule and send you off first, Gianluca. Okay, Gianluca, why don't we kick it off with a clinical case? Thank you for your flexibility.
Perfect. Thank you so much. I want just to start with this brief presentation about our clinical experience in Monzino in Milan about the use of the FFRCT in real clinical world and clinical practice. I want just to show you two cases that are extremely useful to improve our experience in the real world. And the first one is a typical case in which, thanks to the use of FFRCT, we can avoid further non-invasive stress tests as gatekeeper to invasive coronary angiography. I want just to show you some information about the clinical history of the patient. This is a typical patient usually referred to cardiac CT, a 61-year-old man with multiple cardiovascular risk factors, but this patient has no diabetes, who was symptomatic for a typical chest pain. If we apply the Diamond and Foster criteria, in which we cross the symptoms, characteristics, age, and gender of the patient, the pretest likelihood of coronary artery disease of this patient is 59%. This means that this is a typical intermediate to high risk patient. If we look just the guidelines of the European Society of Cardiology, they suggest usually the use of cardiac CT in the low to intermediate risk, and usually it suggests the use of stress test in a patient with the intermediate to high risk patient. So this is not the perfect setting in which we can use cardiac CT in a clinical practice. In any case, we have scanned this patient with the CT. Just a couple of information about the scan parameters of this exam. The body mass index of the patient was low, 22, and so for this reason we have used the low tube voltage during our scan, 100 kVp. The heart rate of the patient was not stable and a bit high, so for this reason we have used the multi-phase acquisition window ranging between 40% up to 80% of the cardiac cycle. But during the scan phase, the heart rate was stable, and so the best image quality was reached in a diastolic phase, 75% of the cardiac cycle. Of note that despite the multi-phase acquisition, we reached a very low effective radiation dose, 2.1 millisievert in this patient. What we found in terms of cardiac CT. Okay, this is the multiplanar reconstruction of the left anterior descending artery, in which we found multiple plaques in the proximal and middle segment of the left anterior descending artery. Here, and in this site, we found a calcification. On the contrary, here we have a narrowing of the lumen due to the presence of a fibrolipidic plaque. If we perform a quantification of the degree of stenosis, in this point, the range of stenosis is between 50 to 7% in agreement with the SCCT score provided to report this kind of exams. Just a couple of comments about this area and this lesion. There is a huge calcification here, so we cannot sure about what happened at this level, because we can have obstructive or non-obstructive coronary artery disease when you have a severe calcification, like in this case, from anatomical point of view, is a bit challenging. If we move to left circumflex artery, the vessel is show a good patency, but here we have just a focal binary calcification in the middle segment of the left circumflex artery. If we enlarge our images, you can see here that, again, a bit complicated to provide a precise estimation of the degree of stenosis due to the presence of a blooming effect related to the presence of two calcified lesions. So in this case, we can say obstructive coronary artery disease, but we cannot be sure. If we move to right coronary artery, we are more lucky here because there are a couple of calcification. We are quite consistent that there is no significant coronary artery stenosis in this patient. So for us, there is no significant disease from anatomical point of view on this vessel. Okay, so now we have a moderate, more moderate stenosis of the LAD. We have an undetermined coronary artery disease on left circumflex artery and no obstructive coronary artery disease on right coronary artery. In the real clinical world, when we have this kind of patient symptomatic for chest pain, we have two different scenarios. A more aggressive scenario, that means to refer the patient based on this CT findings to CAT, to perform eventually an invasive FFR in case that lesion on LAD is confirmed, or we can refer to a patient to a stress test as gatekeeper to CAT. In this case, usually a second level stress test is highly suggested based on the local expertise. So a stress echo can be suggested, or as alternative, SPECT or stress MR. But in this specific case, as you can imagine, we have the FFRCT in the same dataset. Now we can analyze the value for each vessel. This is left main artery and left anterior descending artery. In this region where we have found the anatomical disease, is followed by a reduction, a significant reduction of the FFRCT, because we observed already in this area a value of 0.71, and the lowest value was reached at the apical segment of LAD that was 0.66. If we move to the left circumflex artery, do not forget that we have a binary calcified lesion on left circumflex artery that was very difficult to estimate in terms of degree of stenosis. But in this case, the FFRCT helped us to take a decision on that vessel because there is no pathologic fractional flow reserve. It started with a value in the proximal segment of 0.95, and the lowest value was reached at the apical segment, more distal segment, but it was a normal 0.87. No doubt about the right coronary artery, because it was normal from anatomical point of view, and it was normal from functional point of view as well, because again, we have a 0.96 in the proximal segment of right coronary artery, and the value is still normal also in the more distal point of the right coronary artery. Okay. Based on this evidence, we have a lesion, obstructive coronary artery lesion associated with an FFRCT. This is enough from our perspective to decide to refer the patient in this specific case to CAT to confirm this lesion and eventually to be treated. For research aim, in this case, in this patient, we have also perfusion study with CT, and this is very useful just to reasoning to discuss about the comparison between FFRCT and CTP. This is the perfusion at rest that was completely normal, and this is the perfusion at stress that was positive in the septum and in the anterior wall, as you can see, but it was positive in the lateral wall as well, a huge perfusion defect in the lateral wall. So it seems that there is a disagreement between perfusion study and FFRCT analysis. The patient was referred to CAT. This is the invasive cholangiography of the left coronary artery. As you can see, find the lesion on left circumflex artery and the lesion here on the left anterior descending artery, exactly in the same point that was detected by cardiac computed tomography. But when we this is the right coronary artery on the other side that is absolutely normal. We performed the FFR, invasive FFR for research aim in this case in all vessels, and what we found that the only pathologic value of FFR was reached in the left anterior descending artery, and the lowest value found was 0.67. So if we want just to summarize by using the CAD-RADS classification provided by the Society of Cardiovascular Computed Tomography, based on anatomical evaluation, I mean CT, we have the highest level of the disease is an intermediate stenosis of LAD. In this case, usually a functional assessment is highly suggested. But we have already a functional assessment in the same dataset, that is FFRCT, that was pathologic, and this suggests to refer the patient to CAT with potential indication for PCI on revascularization on LAD. In this case, stress CTP is a little bit in disagreement because it confirms what we found on LAD territory, but there is a positive perfusion defect in the lateral wall of the left ventricle. But when we refer the patient to CAT, the CAT showed from anatomical point of view one vessel disease, and when we apply invasive FFR, the invasive FFR confirmed the one vessel disease, as showed by the integration of the information by CT and FFRCT. So the final message of this case is that FFRCT is a very useful tool to detect the relevance of a coronary artery disease, but as compared to other approach, for example, stress CTP, provide a per lesion evaluation rather than a per territory evaluation, and this is a potential typical case of a false positive perfusion defect with CT in the lateral wall that, as you know, is suffer for beam hardening artifact, and that is the typical location in which we can have false positive cases.
Maybe we could just open it quickly to questions. I mean, that's a fascinating case, Gianluca. I think it highlights one of the advantages of really of pinpointing ischemia, obviously, with FFRCT. Even we talk about a one-stop shop with CTP and anatomy, but it can be obviously a very powerful test, but it's still obviously limited by a whole different set of image artifacts, as well as the fact that ultimately it's hard to discriminate where the increased resistance to flow is actually going, right? Whereas FFRCT, what we found, and maybe you can comment, is that you can not only get a calculation of pressure proximal and distal to the stenosis, but then in the distal vessel as well to understand the overall pressure loss across the entire territory. I don't know.
Yes, if I can just add one comment on that, as you know, we are doing a lot of experience in both field, and behind the undoubtable advantage of the FFRCT that does not require a second scan, a second contrast agent injection, and no use of stressor that is sometimes a bit complicated. Behind this aspect, that is a technical and practical aspect, the difference regarding to a technique that provides the per lesion information as compared a technique that provides per territory information is crucial in the planning of revascularization strategy, because as you can see, especially in the patient with multiple vessel disease, sometimes the perfusion defect is a little bit not really useful, because does not give us the information that we need to decide what we have treat. So this is the real crucial point, the crucial difference between these two different approaches.
Any other comments? I see people who do perfusion, both Dr. Niemann and I see the MUSC group. Anything further to add about how you implement these two complementary but different technologies, or?
No, it is interesting to see the comparative results. Yeah, this is Koen Niemann. So we tried this as well. In our study, we tried two different techniques. We compared the Siemens FFR with a dynamic perfusion. So both of them are a little bit slightly different. And in this case, we found comparable accuracy, but also complementary. So there are some cases where the FFR didn't work so well, but then we also had cases where it worked really well and actually correlated better with invasive FFR than the perfusion imaging did. So yeah, so those cases we do see. Apparently, it's not exactly the same.
Interesting. So it's a great start of the session. Dr. Norgaard, please.
Thank you. These are my disclosures for my short talk here. Basically, what is the overall goal for coronary CT angiography acquisition? That is to provide images with a clear, high contrast view of all coronary arteries and plaque-free from artifacts affecting visibility of the lumen boundary using the lowest possible radiation dose. But then, what's the goal of CT for subsequent FFRCT assessment? Well, it's very important to highlight from the beginning that the goal CT-wise for FFRCT assessment is exactly the same for us coronary CT angiography per se. Based on the recent technological advancements in CT acquisition techniques and the growing body of evidence on the optimal performance of coronary CT angiography, the Society of Cardiovascular Computed Tomography recently came up with an update on the 2009 Best Practice Coronary CT Angiography Guidelines. In this short presentation, I'll discuss issues related to patient selection, patient preparation, CT acquisition, post-processing, with special focus on patient preparation, especially the importance of rigorous use of beta blockers and nitroglycerin in all patients, taking into account my own experience. Although it may seem trivial to many, the importance of proper patient selection for image quality is often forgotten. It should be acknowledged that coronary CT angiography assessment cannot be performed in all patients, and that CT visualization of the coronaries being small structures moving up to 5 centimeters per heartbeat is challenging. In fact, the most challenging discipline in the field of cardiac CT. It should also be acknowledged that patient-specific factors and weight, the presence and severity of coronary calcification, heart rate, and heart rate variability and cooperation are important factors in order to obtain a good and diagnostic outcome. In my department in general, I say that we can deal with one artifact issue, but not two. Thus, for example, if the patient has severe calcification, the heart rate should be perfect and the weight optimal. Combining a high and irregular heart rate and severe calcification most often will compromise significantly the diagnostic value of the test. Of course, as important is patient preparation. Continue all regular medications except for phosphodiesterase inhibitors and long-lasting nitrates. I'll come back to that in a moment. Do not use caffeine products. In my department, we say do not use such products within 12 hours up to the scan. Well, what about smoking? It is well documented that smoking reduces the diameter of the coronaries and that smoking attenuates the vasodilatory response to nitroglycerin. In our department, patients are not allowed to smoke 2 hours before coronary CT angiography. I will not go into details about education, coaching, and preparing the patients, of course, are essential still in coronary CT angiography. efforts on minimizing patients' anxiety should be taken. Practice breath hold. Ensure breath hold time will be sufficient for scan time. Evaluate impact on breath holds on heart rate. A good ECG signal and sufficient IV cannulation should be secured. I'll spend some time on the importance of good heart rate control and image quality, and in order to reduce the radiation dose. In this study from the Achenbach group, they showed that even when using the CT dual source scanner having the highest temporal resolution of all scanners, heart rate significantly influenced on image quality. Perfect image quality without any motion artifact, as indicated with a score of 0, was most frequent in patients with a heart rate less than 60 beats per minute, as can be seen here, and very rare in patients with a heart rate above 80. This finding was independent on which vessel territory being explored, as shown here. In another study by the same group, they found even by expert reads that the proportion of at least one unevaluable segment increased with increasing heart rate. In patients with a heart rate less than 60, only 3% of the patients had at least one unevaluable segment. And look here, even though that we just raised the heart rate to between 61 and 65, as many as 21% of the patients had at least one unevaluable segment. Accordingly, the updated SCCT guidelines on best practice on coronary CT angiography recommended that the target acquisition heart rate should be set at 60 beats per minute. Of course, CT angiography can be performed at higher heart rates, but at a price not only on image quality, also on a price of a higher radiation dose because of less probabilities of using prospective scan. And this irrespective of what the vendor representatives might say. As late as yesterday, we had a vendor representative here, and he told my staff that with this and this new feature, heart rate is of no influence on image quality. I had to tell him that this is totally undocumented and emotional, not according to my or my staff experience, not according to the literature, and basically not true. This should be acknowledged. A few words on how we practice heart rate control in my department. We do around 2,500 CTs for coronary assessment per year. Before doing CT, the referring physician has provided us with information related to beta blocker contraindications, asthmatic disease, AV block, intraventricular block, left ventricular function. Our pre-treatment regime is that based on an ECG that we have access to on beforehand, we send to the patients a atenolol of 100 milligrams in the event of a heart rate more than 60 beats per minute. If it's a small patient, we only send out 50 milligrams. We tell the patients to take the medications approximately 3 hours before the scan. In the event of contraindications to beta blockade, we send out ivabradine and tell the patient to take it 15 milligram 1 hour before the scan. About 30% of our patients that receive oral beta blockade need additional IV beta blocker at the time of the study in order to obtain the target heart rate. We use metoprolol, 5 milligram boluses, and our top dosage is 20 milligram. Rarely we use IV esmolol, which has a rapid onset, a very short duration time, especially in patients with heart failure. Following this regime in our institution, a target heart rate can be obtained in 85% of the patients. Beta blockers we administer in 80% of the patients, and ivabradine in 5% of the patients. Severe side effects to beta blockers are advanced AV block, bradycardia, bronchospasm, and worsening heart failure. However, by pre-screening of patients, such incidents should be avoided or at least be extremely rare. In my own experience, taking into account 8,000 CT scans in which we administered IV beta blockers, only 5 patients were categorized as having severe side effects. One's asthma, and 3 with advanced AV block. None of these were fatal. In summary, benefits of beta blockers are that they minimize coronary motion, minimize misregistration artifacts, and decrease radiation dose by allowing increased use of prospective gating. I'll spend a little time on the use of nitroglycerin. For some reason that I frankly do not understand, still many centers do not use nitroglycerin as routine before coronary CT angiography. In Denmark, 15% of centers do not use nitroglycerin routinely. First of all, FFRCT cannot be assessed reliably without the use of nitroglycerin, since this is one of the premises for the FFRCT computational model. Also, nitroglycerin has a significant influence on vessel interpretability that I will come back to in a moment, and it may attenuate the potential coronary vasoconstriction induced by beta blockers. In this rather small but quite elegant study by De Kramer and colleagues, patients were randomized to no or to sublingual nitroglycerin before 64 multi-slice CT angiography. Patients were matched on age, sex, BMI, and calcium score. The effects on coronary lumen diameter and volume using a dedicated software in LAD and RCA, a number of visualized septal branches were assessed as shown here. As can be seen, the use of nitroglycerin resulted in a significantly higher diameter in both RCA and LAD, higher volume, and also higher recruitment of more small side effects. Of note, in this study, there were no difference between groups regarding side effects and blood pressure and heart rate. The effect of sublingual nitroglycerin before CT on CT diagnostic performance has been tested in several studies. The findings are consistent across all studies, with nitroglycerin being safe and resulting in increasing diagnostic performance, as in this study by Yu and colleagues, where nitroglycerin spray 1.4 milligram 1 minute before CT resulted in increased diagnostic sensitivity, specificity, predictive values in both proximal, middle, and distal segments. Okay, and also this study, I forgot this study. This is a very important study by Tax and colleagues. It's a meta-analysis including all the diagnostic performance, assessing the influence of nitroglycerin of CT diagnostic performance. I will not go into detail, but highlight their conclusions, stating that sublingual nitroglycerin administration results in significant coronary artery dilatation. Nitroglycerin increases the number of evaluable coronary branches. Image quality is improved the most in smaller coronary branches. Nitroglycerin increases the diagnostic accuracy of coronary CT angiography. Most side effects are mild and do not require medical intervention. Okay, sublingual nitroglycerin is necessary. Should we administer tablets or spray? In my department today, we use spray only. With tablets, we often experience that they were not fully dissolved after the scan and thus apparently wasn't of much benefit. In this elegant study performed in the cath lab, patients were randomized to either capsule or spray 0.8 milligram nitroglycerin using intracoronary 0.2 milligram nitroglycerin as the reference standard. The effect measure was changed in proximal vessel diameter. Patients who received nitroglycerin capsule, as shown here, as the first application, had no significant change in vessel diameter when compared to the baseline. In contrast, patients who received spray nitroglycerin had a significant increase in vessel diameter, as shown here, close to the maximum response as assessed after intracoronary nitroglycerin. Of note, there were no significant changes in various hemodynamic parameters between groups. When should nitroglycerin be administered? Based on the hemodynamic response as assessed by the systolic and heart rate, blood pressure and heart rate, it has been suggested that nitroglycerin is best administered after 3 minutes. However, these findings are, to the best of my knowledge, based on the use of tablets. In my practical experience, and also according to the literature, after spray, patients report headaches typically already after 1 minute. Thus, in our department, using spray only, the recommendation is to do the CT after 1 1 to 3 minutes. In my experience, the often discussed reflex tachycardia potentially induced by nitroglycerin is of no practical importance. However, this may be due to the fact that most patients in this department are pre-treated with beta blockers. Thus, as highlighted in the SCCT guidelines, the use of nitroglycerin should always be used before coronary CT angiography. In my point of view, a coronary CT angiography without the use of nitroglycerin is not a real coronary CT angiography. In my department, all patients receive pre-scan nitroglycerin 0.8 milligrams before the scan. If for some reason more than 3 minutes occur up to the scan, we give additional spray 0.4 milligram. Sublingual nitroglycerin is safe, and most often the side effects such as headache are transient. In my department, the only absolute contraindication to nitroglycerin is the use of phosphodiesterase inhibitors such as sildenafil for the treatment of erectile dysfunction or pulmonary hypertension or long-lasting nitrates. If the patient in my department do not, for some reason, want nitroglycerin, we don't do the scan and refer the patient instead to some other kind of testing. In my department, only about 1/3 of the patients report that they have side effects. We spent some time on information before the scan about nitroglycerin side effects, so they are prepared for this maybe slight dizziness and headache. We tell them that it's a good thing to have a headache because it tells us that the medication actually works and that we will get the best diagnostic result. In summary, use nitroglycerin during CT acquisition, preferably 1 to 3 minutes prior to image acquisition. Inform patients about side effects, especially headache, so they are prepared. Use 2 sprays, 0.8 milligram. Use a beta blocker may avoid reflex tachycardia. Ask patients not to take any nitrates 12 to 14 hours prior to CT acquisition. Do not smoke right before the CT scan. With regard to coronary CT angiography acquisition, following our rigorous regime on selecting the right patients, use of heart rate control and nitroglycerin in all patients. In this department, prospective ECG-gated acquisition is performed in more than 95% of the patients, resulting in a mean radiation dose, including the CAL score assessment of 2.4 millisievert. With rigorous selection of patients and planning of the scanning, retrospective scanning being associated with a high radiation dose can be avoided in most patients. Again, what's good for coronary CT angiography is good for FFRCT. A few words on post-processing techniques in relation to FFRCT. Today, with the new platform for FFRCT assessment, it can be performed with both diastole and systole phases. We typically upload a couple of phases, so HeartFlow has something to work with. With regard to iterative reconstructions, this is okay as long as the lumen and plaques can be visualized. As for CT, FFRCT involves precise measurements made on vessels. As for CT, artifacts may impact FFRCT. FFRCT is based on a detailed 3D model of the coronary tree and the myocardium. Smaller vessels are important. With regard to field of view, it is important to include the total myocardial mass, so be aware not to include also the inferior wall that we sometimes tend to forget. In the event of a high calcific burden, use as little field of view as possible. Shortly on FFRCT artifacts, these data are from the next trial. The top 3 artifacts leading to image quality being inadequate for FFRCT analysis were misregistration, blooming, and noise. Again, avoid artifacts by proper selection of patients. Beta blockers also take into account that you may be able to optimize MA and KV, and there may also be issues on contrast. There are no time to go into detail on that. Today in our center, we have used FFRCT in our routine practice for almost 3 years now. We have recently, for this center, published our first real-world data showing feasibility of this method. It is often stated that FFRCT assessment is not possible in a large proportion of patients. We can show by sticking to the guidelines, SSCTD guidelines of best CT practice, especially regarding rigorous heart rate control and the use of nitroglycerin in all patients, that we receive a conclusive FFRCT result in more than 90% of the patients, which is in fact a higher proportion of conclusive results when we compare to the time when we used nuclear testing, at least in this department. Well, I have to stop now. These are my final comments. FFRCT is derived from precise modeling of the coronary tree, not just areas of disease. Coronary CT angiography best practice equal best practice for FFRCT. Scan optimization is essential in unlocking the potential not only for FFRCT, also for coronary CT angiography. Best practice coronary CT angiography is achieved by incorporating practice from the 2009 and 2016 SCCT guidelines on how to perform CT angiography. Usually small incremental protocol variations are all that is required in order to improve significantly your CT quality. Vasodilatation with sublingual nitrous is essential both for CT and for FFRCT assessment. And it is important that the physicians and staff doing a coronary CT are comfortable with the use of beta blockers, both orally and intravenous. Thank you for your attention.
Thank you so much, Bjarne. That was a great overview, really highlighting the importance of best practice for cardiac CT, which is clearly best practice for FFRCT. Appreciate you taking the time. I open it to the floor for any questions or comments. Are most sites using a metered spray for administration of nitroglycerin, and if so, are they using 1 or 2 puffs? Or
yeah, this is Koen. Yeah, we usually use 2 puffs. Often find that the first puff is only half a puff. So I use 2, maybe 3 puffs every now and then. We did run into some problems where we had one patient, I think, probably with somebody with aortic stenosis, and didn't do so well. So then for a while, the technicians couldn't deliver it anymore and had to be a doctor. I don't know whether other sites have that problem, whether technicians are allowed to give the spray or it has to be a physician. It's something that we ran into.
This is an important point. We're actually going through what we call a transfer of function, where technologists will be able to do this, because historically we've had actually patients administering, and if they're naive to using it, they don't deliver it very well. So it's a good point.
Well, in
yes,
my department, CT is performed by the cardiology staff. So the staff they have a long tradition giving these drugs, both intravenous beta blockers and nitroglycerin. So here in Aarhus, all preparation of the patients are performed by dedicated nurses. No doctors are involved in this.
If this is Gianluca, if I can add just one comment, we use nitroglycerin as well before the acquisition, but very important to train the nurse that the administration of nitrates is accurate, is well done, because otherwise the effect of the nitrates is not maximal. For example, in our experience, in which we have in the same patient the acquisition with the nitrates, I mean the rest CT dataset, and then the acquisition under adenosine effect, sometimes the effect in terms of vasodilatation is absolutely different between these two settings. And in a lot of cases, because the approach of the nurse is not so perfect in terms of administration of nitrates. So it's very important to be sure that the drug is in the mouth and it reach the target area.
Yes, I couldn't agree more, and I don't know who should address this, but I think for people on the phone, I think you drove home the point so well, Bjarne, about the value of nitroglycerin not only for coronary stenosis evaluation, which I think is really established, but also how important it is for not just modeling of FFRCT, but the reality is best practice invasive FFR relies on it. So to simulate similar conditions as to the invasively measured FFR, it's really essential that nitroglycerin is administered. And you made a comment which really resonated with me. You said if the patient is unwilling or cannot take nitroglycerin, you refer them to another test. You simply don't proceed because you know the yield is going to be significantly reduced, which is, I think, a really important message.
Hi, it's Lynn from Duke. Can I ask a question?
Of course.
So I completely agree with everything that was said, and I have a question for those on the call. We've sort of run into times sometimes where we have to make a choice about beta blockers versus nitro when patients are coming in with a relatively low blood pressure, or having to change how much beta blockers so we can make sure we can give nitro. And I just want to know, are others facing this situation, and how do they handle it?
Well, my experience is that in patient, well, it depends on the cause of the low blood pressure, but in fact, if you give 2 puffs of nitroglycerin in the patient with a blood pressure, in a stable patient with no acute coronary event, blood pressure systole on 100, for instance, it doesn't really affect the blood pressure in these patients. That's my experience. So as long as the patient is stable, I'm not worried about the blood pressure. And the same goes for IV beta blockade. Again, stable patients.
This is Koen. Unless the patient is decompensated, and probably ivabradine doesn't have as much effect on blood pressure either. So that could be an option as well. But you have to ask why the patient is tachycardic and has heart failure and low blood pressure. So I guess you would have to be a little bit careful about that and wonder whether it's the right time for the test.
Yeah, I think you hit the nail on the head. We had a case recently that patient had new onset atrial fibrillation and heart failure, and of course they send us for coronary CT, and as you mentioned, the patient's actively being diuresed, has been into the emerge 4 times already, and is on diltiazem for reasons that are unclear, right? And we'll never be able to rate control the person properly, and obviously we couldn't give much beta blocker, and inevitably things don't go as well as you would like. So there's, I think, Bjarne, another comment you made, which was really important, is that it's not the test for everyone, right? I mean, you have to do it well. We have in cardiology and cardiovascular medicine other testing, so you have to do the right test for the patient at the right time. So, and if you're going to do it properly, though.
This is Bjarne again, sorry, but in my department we don't do CT in patients in whom that we don't have an updated ejection fraction, left ventricular ejection fraction. We have an ECG. So we have the patients evaluated in our outpatient clinic within the last 2 weeks before the CT scan. So if you don't have information on the left ventricular ejection fraction, of course, there may be problems both with regard to nitroglycerin, especially with regard to the use of beta blockers. I've seen centers where they didn't even have an ECG before they gave beta blockers, and this is not acceptable in my point of view.
Yeah. Okay. Well, this happens sometimes in other places, of course, where I mean, sometimes we know the patients, but I mean, what you have, Bjorn, is a luxury that you know the patient before you can send the medication.
Yeah.
Unfortunately, we did not always have that luxury, to be honest.
Yeah. No,
You're welcome here, Cone. You let me know.
So I
I'll be there after
know,
summer.
I know, Gianluca, you had another case. I think we're pushing up against the clock just because, I think your case. But coming back to it, maybe I could just ask you one question. How do you determine who you're going to use CT perfusion? Oh, this is for you, for Daniele. CT perfusion versus FFR CT. And do you make that decision before you see the baseline anatomy, or do you wait to see the anatomy and then repeat the study with stress, or just send for FFR CT?
At the moment, to be honest, we are just using stress CTP for research aim. So our clinical workflow at the moment is considered just CT plus FFR CT, and we are doing just stress CT in a controlled study just to be sure that is powerful and it is robust. In my perspective, I think that probably a potential future scenario could be the following one. We have the first step that is a CT, that in case it's negative is usually enough to rule out the presence of coronary artery stenosis. In case it's positive and you do FFR CT and this is negative, that is enough. In case you have a positive FFR CT, you have two different kinds of patient. Patient in FFR CT there is a little bit of noise. In case there is one scenario in which the FFRCT is a clear positive, and so it's cool to refer the patient to CAT. And the second setting is a patient in which FFRCT is mild positive or is not consistent with anatomy. So this is probably a small setting in which we can refer the patient to stress CTP. So I imagine the FFRCT as a potential gatekeeper to decide if we really need the stress CTP or if we can skip this phase.
Okay, that's helpful. Okay, well, I thank you both for excellent talks and excellent case presentations, and I thank you all for participating and engaging. There's a planned webinar, I believe, after the integration of the new reporting software. We'll have a webinar that will be done in late February, which will be something to look forward to, which is going to be done with a number of people, including Dr. Hurwitz, who's on this call. The idea being focusing on how to interpret FFR CT results, which is obviously very important, and the whole discussion around distal to the stenosis for the distal lowest value. So that'll be something to look forward to. But again, thank you, Gianluca, for taking the time. I know you're away from home, but sharing us that excellent case, and Bjorn for the tremendous talk, and all of you for your attention. Thank you.
Thank you, Jonathan.
Thank you to all for your attention.
Be well.